All
Thank
right.
you.
All right. Hey, this is Shannon, and tonight we are going to be talking about vision and stroke. And so I have a specialist here to educate us all about that a little bit more. So this is Amy Geddes. I'm going to let Amy talk to you a little bit about herself, about her background, and how she knows a little bit more about vision and how it relates to stroke survivors. So take it away, Amy.
Hi, well, thanks for having me. So, I'm Amy Geddes. I'm an occupational therapist by trade. And so, my degree is from East Carolina. And when I started my career in 2001, I went into the neurological population. And one of the biggest areas of challenge after stroke or brain injury is vision. So, although there's not a specific specialty in vision or certification in vision, there is a lot of continuing education and a lot of extra courses and training that you can take to help you feel more confident and comfortable in helping people with those kind of issues. So I have a lot of extra training in those areas, and we see a lot of it and treat a lot of it in the outpatient clinic that I work in.
All right. And so right now you are working in a setting where you're only seeing stroke survivors and brain injury survivors, right?
That's correct.
Okay. So you have lots of chances to practice this and see a lot of different varieties of issues with it.
Mhm.
All right. So the first thing that I want to talk about is the difference between sight and vision, right? Because that's something it sounds like that comes up for people and that can be confusing. So talk a little bit about that.
Sure. So that is a confusing area for people. So sight is actually just one part of vision. And sight is also considered acuity. So that 20/20 number that we hear. And so it can include things from far away or it can include things up close. So most people at some level in their lifetime will have an issue with their sight. So as we age, we
Yes.
need readers. But
Yes.
some people are born with sight issues. So I wear contacts, and so I have an issue with my eyes. And so most sight issues are corrected with some sort of lenses. So whether it's contact lenses or eyeglasses or even LASIK. And so it's usually easily corrected. Um, so vision includes sight. It's a really important component of sight because obviously your brain can't process information if it can't see it. And all of that information coming in through your eyes is really important. Low vision is included as a sight issue, and that's a whole other subspecialty, low vision and blindness. So there is an area of that that comes with just sight issues.
Okay, and so then low vision really just relates to that acuity piece.
Yes.
Okay. All
Yeah.
right.
So if your say 20 number for near vision is like 2200, we would start using some strategies for low vision.
Okay. Okay. And then so if a person has a stroke and they're having vision difficulties, how does that work? How does your brain and an injury to your brain cause problems with vision?
Yeah, so there's three major types of vision issues after a stroke or brain injury. And the first one, which is the most common, is a visual field loss, or sometimes called a field cut. And so this can include any part of your visual field. So sometimes people will say, "Oh, I have trouble with my peripheral vision,"
Hmm.
but it can also be just a little section of your vision, or even what's called a scotoma, which is kind of like a blind spot. It's not, in a specific spot in your field of vision. It's just a little kind of whole blind spot. And so, obviously, if you have a visual field loss, you're going to have trouble with reading and mobility. You could miss obstacles, your balance could be impaired, you have trouble using your environment, you're missing things. And so, this usually occurs when there's damage to the pathway. So, I think we have a picture.
Okay.
Um, so, let's pull up the visual pathway. So this is, and there's actually a lot more involved with your visual pathway than just this, but these are kind of the most common ones. And so you can see based on the damage of your visual pathway is how you'll have a presentation of visual field loss. So in number one, it
So
really,
real quick, I'm going to jump
oh,
in.
sorry.
So
Yeah,
just
go
so
ahead.
we can sort of orient. So
Yeah,
these things
those are your
up
eyes.
front, those are your eyes. So this
Uh-huh.
person's looking up, up in
Yep.
this direction. And then, so this is the back of your head back here
Yep.
where it says
That's the
visual
back of your
cortex.
brain.
Okay.
Yep.
So,
So,
all right. So we're back here at number one, then this
right.
little number
Yep.
right
So
here.
number
Okay.
one is your right eye. And so you can see where they have sort of a line all the way through the entire visual field pathway. So
Okay.
that is the entire pathway. It's all the nerves that are connected with that eye. So if you have that, the damage occurs there, then you will lose all the vision from your right eye.
Okay.
And
So up
that
here.
also includes your acuity in your right eye. So that's where that sight component comes in.
Okay.
So
Okay.
you won't have any visual information coming into that right eye and making it back to your brain because the damage is getting cut off at that visual pathway.
Okay.
So number two, which is kind of right in the middle where your visual pathway connects both eyes. So information's coming in from your right eye and your left eye, and it kind of crosses there. If that happens, then you will have the right side will be kind of your outer eye, and then your left side will also be your outer eye. So this is a true kind of visual field peripheral deficit, and you'll have what we call central vision. So you'll be able to see kind of like a tunnel in front, but you'll miss your peripheral vision on each side. So one side, your left side will be gone and your right side will be gone. So if you look at 3, which is over to the left side, part of your visual pathway stays intact, but part of it,
So like this little piece right here
that
is
little line.
saved that goes
Yep.
across. Okay.
And so that's a
then
nerve.
This one,
And so that one gets damaged. So your right eye will have no trouble, but your left eye, the part of your eye from kind of the middle of your eye over to your nose, you'll be missing that part. So anything that kind of lands right in this little area, sorry, Pat. Sorry about that. So anything that lands right here in your nose, if this eye was covered, you wouldn't be able to see.
Okay.
But because my eyes work together, if both eyes are open, since this right eye doesn't have any problem, it should be able to pick up any information that this eye isn't seeing.
Okay. Okay.
So if we move down to 4,
Okay.
so
So here.
this is the most common type. And if you did another 4 on the right side in the exact same place,
Here,
exactly,
like
it's going to give you those visual field deficits. So the picture shows a right homonymous hemianopsia, but if it were on the other side, it would be
the line were here and not there. Then over here, these two black, it would be flip flopped.
It would be the reverse. So more like what 5 looks like without that little cutout.
Oh yeah, gotcha. Okay.
So that right there, because it took out all the damages to all the nerves in the visual pathway right there. You're getting a true visual field on your temporal side and field on your nasal side.
Okay.
Eye is just seeing this half if it were the right side and just half if it were the left side.
Okay.
And then back a little further back, and this isn't as common.
Yeah, that was interesting to me when I saw this.
Yeah.
Okay.
So we don't tend to see this as much. When we do see this, it does tend to be more when there is a neglect component, and we'll talk about that next.
Okay.
That's where they have that visual field loss, but they have a little cutout that gives you a little more central vision. but because it's really close to your visual cortex, we tend to see some neglect that goes along with that.
Okay.
These
And
are
so
all
then
your
this
visual
part of
field
your brain back here is where, like, I don't want to use the incorrect words, but so that's sort of the vision center of your brain
Yes,
where all these
that's the
connections come.
processing center.
Okay.
So a field cut or a visual field loss, there's actual damage to these pathways.
So
So
any of
again,
these
depending
lines.
on where it is, you'll have a specific presentation. And
Okay.
again, there's other types. These are just kind of 5 to kind of get you started, but you could be missing just part of the lower quadrant or part of the upper quadrant. Again, sort of based on where it is in this visual field.
So then just with that, so it just all matters where you have cellular death because you don't have blood
Mhm.
flowing to an area, and so
Mhm.
it could affect smaller and different parts of these kind of more complex pathways, and that's when you would
Yes, and
see sort of those
sometimes
more
it's
specific.
right, and sometimes it's not specific damage to the actual pathway per se.
Mm-hmm.
It's swelling from the tissue surrounding
Mm.
the pathway. So we do find sometimes there is some spontaneous recovery when it comes to visual field loss. And if that's the case, it's usually because the pathway wasn't actually damaged, the tissue surrounding it was damaged. And as that damage, sort of the blood clears out a little bit, if it's a hemorrhagic, or if the tissue starts to decrease in the swelling, it can reduce the pressure off the pathway, and then we start seeing some improvements.
Okay. Interesting. All right. All right. So
Yes.
that was like the first sort of
Yeah. So
section.
then neglect is another common type. And if you look at the visual cortex back there,
Oh, you want to pull it back up?
that's okay. You can,
Okay.
we don't really need it. So this is neglect is a type of spatial inattention. So there's no actual damage to the visual pathway. The damage occurs in the visual cortex, which is the part of the brain that perceives information. It interprets what our eyes are sending back to it. It can feel a lot like a visual field loss. And actually, the strategies for neglect are similar to what we would do for a visual field cut, but it's actually there's no actual damage to the pathway. It's all trouble with the cortex, and that's the second common type. Now, you can also have them in conjunction with each other, so you can have a visual field cut and neglect at the same time, depending on what type of stroke or what type of brain injury.
Okay.
Then the third type is kind of several issues lumped together, and those are your eye movement disorders.
Okay.
And those can be, a jerkiness of the eye, which we call nystagmus. It can be difficulty with your eyes working together. It can be when an eye turns in or out. And these occur because of the nerves that help the muscles of your eye, or the muscles of your eye themselves are damaged.
And
So,
I did hang on, let me real quick because I thought you would talk about this. So I did pull up a let me look. Yeah. Just a rendering of the eye. Is that what I want to say? Like
oh
a
yeah,
little,
great.
yeah. So we could just because I think it's pretty darn complex when you talk about the muscles. So what you're talking about right now, right, are
Mhm.
like these muscles when they contract, they pull our eye in a
Yep,
different in each direction. And so just like
exactly.
muscles like that we see like on one side of the body and your arm are affected or your leg are affected, you can have these muscles of your eye be affected as well, right?
Yes, and that can cause a different set of issues. It can also, really affect your balance because of the way that your eyes work together. If you have like an eye movement disorder and it's really jerky, the way that you perceive information can make you really dizzy, and it can
Mm-hmm.
be included as part of your vestibular system. So there's a lot of challenges that can come with when there's damage to the muscles, or damage to the nerves that help the muscles. And the big one that we see is depth perception. And so when people can't judge how far away something is, you can imagine they go to reach something and they knock over the cup, or, how that would really affect driving because, if you can't judge space between cars, you're obviously at more risk of having an accident. So these eye movement disorders can get pretty complicated.
And then would double vision, would that occur with the eye movement disorders? Is
Yes.
that okay?
Yep, that's included in the eye movement disorders. Yep. So there's nystagmus, there's double vision, there's eye teaming issues, there's what we call accommodative issues. Um, there's strabismus, which is that turning in or out. I think I hit them all. What
Okay.
we call a saccadic deficit,
Mm,
which is how your eyes sweep an environment. So your eye will sweep, stop, pick up information, sweep back, and all that occurs with milliseconds.
hmm.
If your eyes can't do that sweeping effectively, then you can't get all the information in correctly.
Okay. So, how are these problems diagnosed? Like, who are the healthcare professionals who look at this
Yeah.
aspect?
Sure. So that's a good question. So there's three main healthcare professionals that help with vision. The first is a neuro-ophthalmologist. They have a subspecialty outside of just their regular ophthalmology that really focuses on neurological diseases of the eye. So if you think about someone who goes to medical school, it's their advanced training in the neurological component of the eye. And so they can do a lot of diagnostic components. They can, do surgery because sometimes the muscles of the eye need surgery, and they can do those components. They can also diagnose eye issues like a visual field cut. They can do testing. Um, we're going to talk a little bit about prisms in a little bit, but they can also prescribe prisms and other glasses that can hopefully help with some of these issues. The next type is called a developmental, or sometimes they'll call neuro, or sometimes they're called behavioral optometrists. And they're kind of, again, a subspecialty of optometry where they can diagnose, again, kind of the same set as neuro-ophthalmology. The difference is they tend to also do vision therapy, which is kind of a specialty. Basically, what they do is use different tools and equipment that can help strengthen the muscles of your eyes, or, again, they'll use different tools and techniques. And then the third type is like myself. I'm an occupational therapist. And although we can test and say, oh, I suspect you have this kind of issue, we actually don't have within our scope of practice the ability to diagnose. So we work really closely with the other two specialists to get a formal diagnosis of a visual issue. And then we're really the ones that then train. So we offer strategies, we offer different tools, different activities that can help improve your visual ability, but we actually don't really diagnose anything. So again, we kind of test and say, oh, I suspect you have a visual field deficit. Let's send you to one of the other doctors and get, a formal diagnosis. And we can start treating before you get a formal diagnosis, but it's good to have that on the books.
Okay.
So those are
And,
the three main types.
okay. And so, if you like, so what are some of the interventions? We said that the neuro ophthalmologist has as an intervention testing, and maybe they can do surgery. The neuro optometrist will do testing and has some rehabilitative things that they can offer, and
Mhm.
then that's what you would do as well. So what does that look like if I'm a stroke survivor, and you are assessing me for vision issues and you find something is up?
Yeah. So, so two things that you would need to go to the other two practitioners for is prisms. And prisms are things that can be added to glasses. And based on where you're having your trouble, it can change the way that the information gets into your eye by changing how the light enters through the glasses. So sometimes they'll do what we call base out. and that will pull the visual field in closer to the center. So when you have the glasses on, it shifts everything in your environment a little closer to the center. And then there's some different ways you can turn it to sort of almost like have a false visual field. And those have to be obtained by either a neuro-ophthalmologist or a developmental optometrist. The biggest area that we do as occupational therapists is focus on different strategies. And so scanning strategies is a big one. And those are used for both visual field loss and also for neglect. And so I have a little sort of quick and easy handout that we can look at.
There we go, shrink it down a little bit. This guy, yeah?
Yeah. Okay. So it says to the left, but we also have, it also works to the right. We have a separate one that says to see to the right if you were coming because your right visual field was impacted. And so we've used this mnemonic that we call gazer. And so gazer is, each letter corresponds to a different strategy. And so if you think about what a lighthouse looks like, the top of the lighthouse sweeps left to right to cover the entire area with light so that a ship coming in would be able to see any rocks or potential risk. And so that's the first thing that we teach people is to think about your head as a lighthouse, and you need to sweep your head left to right. A guide is something that you would use to help with sort of your attention and reducing the amount of information that you look at one time. So a lot of times we'll use like our finger to serve as a guide as we travel along. You could use a ruler or a bookmark. So something just to kind of help you keep your place as you're moving along and you're trying to sort of scan that visual field.
And so that would be as you're reading something on a page or reading, like on a computer screen. Okay.
Or if you're even like looking in your environment. So if I'm scanning this room, I would hold my hand up and help it sort of serve as a guide.
Okay.
So it kind of helps you keep your place.
All right.
An anchor is a physical line that you are going to either draw or have it placed, prior to an area that you're having trouble. So I really like painter's tape because you can remove it pretty easily and it doesn't tend to do damage. So if you think about a doorway, if it's really hard for you to judge where the end of that doorway is, if you do a nice bright strip of painter's tape and they have to look all the way to the painter's tape or all the way to the line, then they're less likely to run into it because they know they have to find the line. Same thing with if you're having difficulty with a plate of food and you're missing all the food, say on the left side, you can draw a nice or put a nice line with some painter's tape, and then the person practices turning their head like a lighthouse all the way to the tape that's on the table. We do it when we read or have pieces of paper. Sometimes we'll use a highlighter and we'll have people turn the page and automatically draw a highlighted line right at that left side so that they're scanning all the way over to the left. Mm-hmm. And so that's anchor. The Z stands for Z pattern. In English, we read left to right, top down. Mm-hmm. Having this Z pattern teaches people to start in the top left corner and then scan all the way over to the right and then back down in a diagonal to the next line and then back over. So it's just kind of following a constant Z pattern. Now, again, we will also do what we call chunking, which is include more than one strategy at a time. So when I'm doing these, my finger is my guide for my Z pattern all the way back to my anchor. So if I'm reading this computer screen, I would have a painter's tape line, which is the edge of my computer, and start with my finger, and I would follow it along in a Z pattern. Edging is basically you find the edges of things. So before I walk through the doorway, I'm going to find the edge of the door frame. Before I, if I'm looking in a room, I'm going to find the edge of the room. So the end of the wall or the edge of the counter. So trying to find the edge, the straight edge of something. And that's my starting point with turning my head like a lighthouse.
Mm-hmm.
And then the R is if you're reading, is to read out loud because your brain processes information from a visual standpoint in a different place than it processes auditory information. So this is especially effective if I'm reading, because if I'm reading out loud, it's going to allow my brain to hear the information and not just see it. So it's processing it in two places. The other thing that reading does is if you look at some of these handwritten notes, is it slows you down. So if you have to read something, you have to slow down enough to say the words, and then checking your work, and then obviously just turning your head, not just your eyes. So these work really well for both a visual field deficit and also neglect. They are a challenge to become a habit because we're just not used to doing things like this.
Mm-hmm.
But really practice, they can be very effective.
And so, all right. So we need to be consistent about utilizing these strategies, right? And so
Mm-hmm.
let's say if I have one of these issues that we found up here. So I have a right homonymous hemianopsia, right? And
Yeah.
and I'm going to work on strategies so that I'm going to be seeing that, so that I'm going to be moving my available visual field, right? Like, so the white part
Yes.
over to where I'm missing the black part, right?
Exactly.
So by if I'm doing these things consistently, will this change, right? Like, will I change what my visual field is, or do I develop the habit enough that I'm compensating for the visual field? I don't know.
Yeah, that's actually a really good question. So the challenge with visual field loss and visual neglect is we don't tend to see a ton of improvement overall.
Okay.
So we don't, so again, if we think back to when we talked about sort of that spontaneous recovery, that's really the only time we see improvement, is if by chance there was swelling in the brain that was putting pressure on those areas, and then that swelling went away. Sometimes we see some recovery, but typically we don't tend to see big changes in improvements with visual fields. So you're exactly right. So then what we do is we make sure we compensate for them by putting these strategies into place. So the ultimate goal becomes really being functional despite our visual field or our neglect, as opposed to really seeing major improvements. There are some things out there that say they can improve your visual field. Um, I've looked into a few of them, but most of them can only improve your visual field by 5 to 10 degrees. And that really doesn't give you enough improvement to justify the thousands of dollars of costs that they cost to run the programs. So unfortunately, right now, we don't have a good solution around how to improve these visual fields, to make them better. It's just the compensation for them.
But if I could make this habit enough, then I could compensate pretty well for that visual field loss, meaning
Absolutely.
it wouldn't be as obvious to people maybe,
Mhm.
and or it might not be as much of a negative impact on my life, right?
Absolutely. I mean, we have people that, can go back to reading without difficulty. Um, in the state of South Carolina, you have to have 120 degrees of field of vision. So if you just have partial visual field loss, and you are a champion at using these strategies, sometimes you can even return to driving. You have to have that minimum that's required by the DMV.
Mm-hmm.
But if you have neglect, you don't have any visual field loss. You just have, a deficit in your spatial processing, and you get really good at these strategies, sometimes you can return to driving. So that tends to be the thing that people always want to return to, because it makes us so independent.
Mm-hmm.
So yes, so being really effective with the scanning strategies can make you very functional. It can make you safe in your environment. It can allow you to cross streets without concern. It can get people back to reading and working despite their visual field loss.
And so that was a strategy that you work with people on to be able to implement when they have a visual field loss. And so for some of those other issues that you were talking about, I think, kind of in that group three, sort of the lump of
Yeah.
those other things, are there things that folks can do for themselves and that you work on with them to help improve some of those problems that people develop after stroke?
Yeah, absolutely. So the eye movement disorders, there are things like exercises that help to strengthen the muscles of the eyes. There's a tool that we use called a Brock string that really works on getting your eyes to work together. Um, there's a strategy that works on trying to increase your smoothness with scanning. So we have some computer programs that we use. Formal vision therapy, you know, at a developmental optometrist, they have some different tools like flipper glasses and things like that. We use some what we call red green glasses, and that can help us to determine if you're having one eye that's working harder than the other, and it's preventing both eyes from really working together. And so the red green glasses help to sort of shut the eye that's working too much off and make the other eye that's not working as well work harder, and that can kind of help bring them closer together. We use some patching if someone is having some double vision, which can kind of help clear it up so they can be a little more functional. So there's lots of different tools and activities that we can do that can help those eye movement disorders depending on which one you're having.
And so, if you're having issues with your vision for any of those reasons, how does that relate to fatigue?
Sure, that's a really good question. So, if your eyes are working really, really hard and your brain is working really hard just to get the information in from its environment, you're going to find that you get a lot of eye strain, a lot of mental fatigue. You're going to find that doing something like reading, where you could have read for hours before, you can read for 10 minutes and then you just feel exhausted. So, when your brain is working hard just to process information, it's going to take a lot more of your energy. So, sometimes that mental energy manifests itself as physical fatigue too. And you'll find that you need to take a nap. But, what we usually recommend is if someone's having some trouble with that, is that they instill more breaks. And so, especially if it's an activity like a computer screen, which has a challenge for a lot of people, or even adding some of the blue glasses that have become kind of
Oh,
popular now,
mm-hmm,
those can reduce overall eye strain for everyone, but
mm-hmm.
certainly for someone who's having trouble with processing visual information.
Okay, so I think that was something that was really eye-opening for me and was helpful. To point out to folks who were recovering, and I think fatigue is a not a complaint; it's a problem for people,
For
but to
sure.
realize that some of these things that aren't as obvious really are fatiguing. If you
Mhm.
have some of these issues with your vision on top of everything else, like your system's just having to work that much harder to do the same amount of activity, for
Mhm.
example. And so I think as an occupational therapist, you guys do a great job of talking about that, and it's a management thing,
Mm-hmm.
too, like about being aware of taking breaks and how to work that in. And if reading is the thing that fatigues you,
Mm-hmm.
it's just like it's just like, oh yeah, before your stroke you could run 5 miles. Okay, well,
Right.
you can't just go
Yeah,
back to running five
absolutely.
miles. You can't just sit down and expect to read for 2 hours straight if you're having these
Exactly.
issues, and having some, like, an expectation too of, okay, this is a hard thing even though it didn't used
Mm-hmm.
to be. And so there's a way to move yourself back in that direction to be able to do that for work life enjoyment.
Sure.
um,
Yeah. And we tell people think of energy like a pot of soup. All day long, you're scooping out, bowls of soup. So the goal is to end the day with some soup left in the pot. And so, some of it is just using energy conservation strategies. So if like you said, reading is something that really is mentally taxing and really zaps your energy, then having a plan on how I'm going to take breaks. Or I have a day that is also, I have a lot of physical things going on and I know I'm going to be tired to begin with. Well, maybe don't add too many things that involves too much reading. Or I have this really important thing that I have to do that involves a lot of focus for work. So I'm going to try to make sure that right after that, I don't also plan something really important that involves, reading from the computer for 15 minutes, so trying to kind of be more cognizant of how you're using your energy. So planning a little bit better, kind of prioritizing, also knowing, you know, I always tell people kind of come up with a rating system for yourself. 1 to 5 seems pretty good. So a 5 is the most mentally or physically taxing thing that you're going to do. Don't put 2 5 things next to each other. Do a 1, take a break, and then do a 5, and then take a break, and then, so just kind of being more aware of what those things are that really do make your brain fatigued.
I like that. I like that system. That's very nice. Cool. Um, okay. So, oh, I had a really good question. I can't remember. Oh, you name, so there's OTs, occupational therapists that have more vision training, and then there were the two medical professionals, the
Yeah.
neuro-ophthalmologist, neuro-optometrist. So they're going to be folks who are outside of South Carolina and even outside of our little town that we that we live and work in. So if I'm a stroke survivor and I feel like I have something going on that just hasn't been addressed, because that happens, a lot of things go on with folks after stroke, and so sometimes the vision issues aren't immediately addressed or fully
Mhm.
fully assessed. So how would I go about finding some of these vision specialists?
Sure. So that's a good question. So there is actually some organizations that can help, help you get in the right direction. Probably the easiest for your specific town, though, would be good old Google. So if I go in and I Google developmental optometry in, Greenville, South Carolina, it's going to bring me the options that are available. But again, you could do that. There is an association for developmental optometrists. So you could go through them, you could contact them. But these days with the internet being as effective as it is, Google has made it very easy for us.
Okay.
And so then what I would do is I would contact them. So for instance, in South Carolina, in our sort of general area, there are two developmental optometrists. And one of them takes vision insurance and the other you have to they'll take your visit and then you submit to your insurance on your own.
Mm-hmm.
And so, for someone who really can't afford the out-of-pocket upfront expense, your insurance will pay for it, but if they can't afford the immediate expense, knowing that ahead of time would be helpful, because then you can, sort of plan better and say, okay, well, this one might be closer to my house, but I can't afford that upfront cost, so I'm going to maybe drive a little further to go to the other one. And so that's really the most effective way, is to to kind of just Google your area. But they do have both neuro ophthalmology, they do have an association, and so does developmental optometry. As far as occupational therapy, there's not, a great one-stop place, but any sort of outpatient center that helps stroke or brain injury should have an occupational therapist with some level of training. And so I would again kind of contact them, see if they have someone who's comfortable with vision, and then that just takes a referral from your medical doctor.
Fantastic. Yeah, I think being able to call any therapy facility that you're thinking about going to and just asking about staff, because with what I know to be true is that with stroke, you there's lots of physical therapists and occupational therapists, but not everybody has kind of the specialty that may be the best for somebody who's living with a stroke.
Mhm.
So being able to call that facility and ask about those specifics. So if you are having vision issues, asking if there's an OT on staff who really specializes
Mhm.
in that and has an interest in that. I think that definitely helps folks out. Um, is there anything else that you feel like you want to share with stroke survivors about vision that we did not talk about tonight?
Just that vision is really challenging. It's really complicated, and be patient with yourself. Try to understand that it's not going to happen overnight. Even the strategies that seem very sort of elementary, they're hard to incorporate. So try to be mindful that vision is an extremely complicated system, and also that no two sets of vision deficits are going to be the same. So, what's challenging for you may not be the same as someone who has a very similar stroke or brain injury than you do. And so they're going to present differently. So it has to be really individualized. But just to be patient, because vision is really complicated, and sometimes it's hard when we get frustrated to not sort of internalize it and really make ourselves sort of feel bad about it, and just kind of stick with it, be patient, and keep kind of working through it, and you'll eventually get it.
All right. Well, fantastic. Well, I appreciate you taking time to do this
Of course.
interview
Thank you
and
for having
share
me.
your expertise. Sure, sure, sure. And we may get back with you with some more specific questions in the future, because I know you have a lot of great
Absolutely.
information to share with stroke survivors for sure. So thank you, Amy.
You're welcome.
I'm going